Hey everybody, welcome back to the ECG of the day. My name is Reid, and don't forget that you can download this PDF to follow along. It's linked down in the description below. And don't forget to like and subscribe the video and the channel and all the things. So thank you guys for your support. Let's take a look at this ECG. It's a fun one, and I think it really helps drive some anatomy as well as some physiology. So let's look at the forest, right? And so we look at our QRSs throughout maybe lead 2, and the first thing I notice is that we've kind of got beat, 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 and then a drop, and then we have beat, beat, drop, kind of in this same pattern, right? Beat, beat, drop. Okay, and so, and by dropping I mean really pausing. And so you could, in fact, maybe call these group beatings, right? I've got like a group here, I've got a group here, I've got a group here, right? It seems to be like group, group, group. And so maybe why are we having group beating? And when I think of group beating, the first thing I think of, the most likely thing, is AV block, and not just an AV block, but some type of second degree AV block. Why? Because remember, second degrees are defined as not all P waves conduct to the QRS, but some of them do. And so let's take a look and see what we think is going on. We said these are narrow complex beats, so these are narrow complex QRS complexes, which makes me think that they're being conducted from my AV node down to his Purkinje system throughout the QRS complex in the rapid fashion. And so now I look in front of them, and I do see some P waves, okay? I see some P waves, and those P waves are, well, let's evaluate them. Let's evaluate what the atria looks like. Those P waves are upright in lead 1, and in AVF they are also upright, and so these are sinus P waves, okay? That's good. Next thing I need to figure out is how are those P waves conducting to the QRS? That we do that via the PR interval as a proxy for evaluation of our AV node. And so if you look here, we see that our first PR interval, kind of in this first series, is a little long, right? So that PR interval is maybe 7 small boxes. So that is 280 milliseconds. Okay. Next PR interval, we need to always look through all the different PR intervals, right? We have to always look. Next PR interval looks a little longer, right? That PR interval is, I guess 280. That's 280. This one is going to be like 10 millimeters, and so that's 400 milliseconds. So it's getting longer. And then the last one is even longer, right? It starts like here to here, which is longer than 10. That's more like 12, and so that PR interval is maybe 480 milliseconds. So we see that our PR interval is getting longer and longer and longer, right? You can see that down here. Let's go to V1 to better understand this. So we've got a PR interval that's getting longer and longer until this one doesn't conduct to anything, right? How do I know that's a P wave? Well, you kind of just look at the pattern. When do I expect my next P wave to arrive? Right then, right? And you know on V1 we have these nice flat T waves, so we can see nice sharp P waves. So we've got PR interval that's increasing before it drops. Okay, let's take a look at the next set of beats. We've got a P QRS. We've got a P that takes longer to get to that QRS, and then a P that doesn't have a QRS. And so we get the same thing, gets longer and drop. And so when the PR interval is increasing, 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 what is that type of block? Well, we know that it's a second degree because not all P waves are conducting to the ventricles. And because the PR interval is increasing before it drops, this is a type 1, or a Winkie-Bach, or a Mobitz 1. And so, second degree type 1 AV block, okay? And you can even say with 3 to 2 and 4 to 3 conduction, right? Here we have 1, 2, 3, 4 P waves for every 3 QRSs, and it gets 3 to 2 later, right? So you could say that if you want to be fancy. You can be really fancy. So we have second degree type 1. Remember, we say that that's because of the AV node disease itself, right? That block is right at the AV node. And because the PR interval is increasing, that's evidence of decremental conduction, which is something that we usually don't see evidence of unless there is tachycardia and the AV node is just getting bombarded with signals from the atria. But in this case, we see it at baseline. That's because that person's AV node proper. Remember, the AV junction is composed of the AV node and that His bundle. This is disease. Type 1 is disease of the AV node itself. Type 2 is disease of the His junction. I think it's really important that you understand the physiology because the urgency of treatment is completely different between type 1 and type 2. So go to I have a curriculum playlist on my page, and I spend about 20 minutes per type 1 and type 2 really talking through the anatomy and physiology of that. So we've got some AV node disease here. But we know that when the signal gets passed down to the ventricles, it creates our QRS complex, and we need to evaluate that kind of independently. And so we said it's a narrow complex QRS, and that QRS is upright in lead 1, but it's downgoing in AVF, right? It's like isoelectric in lead 2, so our axis is kind of up and to the left. So we've got some left axis shift. We've got left axis shift, okay? What could cause that, right? When maybe left bundle branch block, but we have a narrow QRS. Could it be a fascicular block? We need to have full left axis deviation for that. So we'll kind of keep continuing to look at that. You see I've got good R wave progression here. I've got small R wave that grows, becomes dominant right around V4, and then it's dominant V5. It's okay. Last thing we're going to do is, for this, is look at our QT interval, right? And so let's find a good lead with a good QT interval. Really, these are all pretty flat T waves, which makes it kind of hard. Let's see. Maybe really the best one I can see is here. And so you can see this T wave is kind of like ends right around there. Looks like it doesn't get within that midway point of those two R to R's, so I'll be happy with that. The last thing we do is we look for pathological Q waves, right? And when you see like a left axis shift, right? If the axis is shifted to the left, like we drew up here in our top left corner, well, another reason why it could be shifted is because maybe there's dead myocardium right here. And so when that signal comes down from the AV node, right, let me get a color that we can see. When the signal comes down from the AV node, it can't go that way. It can only go that way, to the left. So you look for maybe inferior pathological Q waves, right, because that's the inferior. So you look for pathological Q waves in the inferior leads, and look what I find. Lead 3 and lead AVF have these deep pathological Q waves in their QRSs, right? Look at those Q waves. So we have pathological Q waves in my inferior leads, which tells me that there was a previous inferior myocardial infarction. So we've had a previous inferior MI. I actually just did a fun research paper, like kind of like a literature review. Wasn't really any research, but a literature review on the sensitivity and specificity for ECGs for prior myocardial infarction with pathological Q waves. And while it's not incredibly sensitive, it is highly specific. It's like 98% specific. So once you see it, you can be 98% positive that's what has occurred. Pretty cool. And so then we look for active ST or T wave changes for any type of ST elevation or depression. For ischemia or infarction, we don't see any. And so when we put this all together, right, I think we need to maybe get an average rate here. We didn't get our rate, but we can get an average rate where we can count the total number of beats within the 10-second strip, and we can multiply that by 6. So let's go 1, 2, 3, 4, 5, 6, 7, 8. And so we have 8 times, 6. So we have an average ventricular rate of 48 beats per minute, right? Our sinus rate is going to be a little faster, right? If we measure between sinus node to sinus node, that rate's going to be 300, 150, 175 beats per minute is my sinus rate. So my sinus rate is normal, but because of this AV block, my ventricular response is a little low, right? And so got to evaluate what's this person's hemodynamic symptoms, right? Is this person okay? If they've had a prior myocardial infarction, right, like we said in the inferior myocardium, they might have, a touch of heart failure. And if they have a touch of heart failure, can they perfuse their body with a rate of 48 beats per minute without getting congested or getting altered, right? Is their brain getting perfused? Also, I want you to think about maybe what coronary artery supplied the region of the previous myocardial infarction. Can we have any correlation here for that? Well, remember that the right, this is probably my favorite part of this coronary artery, what does it supply? It supplies the inferior portion of the myocardium, and it also supplies the SA and AV nodes. So we would expect a person with a previous inferior infarct to potentially have damage to their AV node, right? It's also supplied by the same artery, so that might explain why we have this second-degree type 1 AV block. Pretty cool. So let's put this all together, and what do we get? We've got a sinus rhythm with a second-degree type 1 AV block leading to a ventricular response of 48 beats per minute. We have left axis shift that is likely best explained by previous inferior myocardial infarction, which is represented by pathological Q waves in leads 3 and AVF. So I hope this helps you understand the physiology and some of the anatomy associated with this rhythm. It's pretty cool. And if you have any questions about it, feel free to message, comment, and chat. Hopefully answer your questions and get you better at ECGs. So thanks so much for watching, everybody. Have a great rest of your day. We'll see you on the next ECG video.